So this was the BEAM trial, though, that we mentioned. And it looked at best practice in primary care versus best practice in exercise manipulation and manipulation plus exercise. You know, large study. I mean, you know, over 1,300 patients. And in general, this is a Roland Morris. This is what they showed that this is best care primary care. That's where they tell them stay active, do some analgesics perhaps, and that's kind of what they talk about there. And these other groups are either, in this group here is the exercise group, and then these other two groups, the blue and the green, are the manipulation in blue and the manipulation plus exercise in green. So these are actually significant differences because they had such big numbers. You could argue this on the Roland Morris, you know, the clinically meaningful difference of that is probably less, but it showed essentially about 5% more improvement when you had manipulation and exercise at 3 months, and even it was significant out to a year that the manipulation plus was the best form of care for patients in the UK coming in with low back pain. So this was the question that was asked was, you know, I apologize for the busyness here, but basically they could have had chiro, a DO, or a PT up to 8 sessions over 12 weeks. And the package of manipulation agreed upon by the chiros, the DOs, and the PTs were here. And they had to at least once use some type of, quote, thrust manipulation or velocity, high velocity manipulation. So they had to at least do that. If they were, any of the providers that saw them, they had to agree to that package of care. So I'm not going to read that to you, but suffice it to say it was a hands-on approach that included at least one bout of thrust manipulation. So that was that BEAM trial that the question came up. This is kind of another trial, Goldby in 2006, that looked at manual therapy, education, and spinal stabilization. And here, we look at this trial, there's not as much in this trial. Actually, the groups did not start at the similar point, so there is some differences on this trial. But basically, showing that education clearly early on, all three of these groups are making a difference, and actually stabilization looking better than the manual therapy group in this trial. Okay, so there's again a conflicting trial when you just throw everybody in and you don't subgroup them, that you generally don't see as large of effect size. Now, I want to give two things, and then we're going to have a little game here. I kind of just alluded to, I made some assumptions here. These data here, this is that when I said this subgrouping concept. What we're going to do is I'm going to talk a little bit about this manipulation group, and then a couple questions came up about this whole idea of subgroup. So I am going to diverge. I loaded some slides. We'll talk a little bit about subgrouping on a bigger scale. But in general, what we found that in these two trials that we conducted, we're involved in, is that in general, about 45% of people respond to thrust manipulation. But when you have 4 or more of these things present, and that's like more recent, 16 days or less, low fear avoidance, so you're not worried about work is going to make your pain worse. You don't have symptoms below your knee, okay? You don't have calf pain. Yet somewhere in your lumbar spine you're stiff, and in general you have good hip internal rotation on both sides. And we can argue what these mean, but suffice it to say that when 4 or more of those are present, people generally do really well, and the likelihood of response was pretty high, so that 9 out of 10 times you're going to expect people are going to do quite well when they have those factors present. Now, the thing I wanted to show was we did a paper in